Hi, I'm Mohamad Mohty from the Sorbonne University in Saint-Antoine Hospital in Paris, in France. And I'd like to give you a snapshot summary about the allotransplant data that are presented during the EBMT 2021 virtual annual meeting in regard to the use of the so-called FLAMSA-like regimens or sequential regimens in refractory or relapsed acute myeloid leukemia. So we know very well, unfortunately, that when it comes to AML, we face the primary refractory patient, but also we have many patients who are in a relapse refractory situation with or without prior transplant. And the treatment options for these patients are really increasing, and we have more and more new drugs being tested or even being approved. However, we should acknowledge that none of these novel agents is curative. And this is why there is still room to test or to use allotransplant in an attempt to cure these AML patients with relapse refractory disease. And that is exactly the spirit of this FLAMSA approach that was developed 15 years ago with the goal to deliver in a single package a cytoreductive intensive chemotherapy followed immediately by conditioning and then transplant, but also immune modulation after transplant with donor lymphocyte infusion and or other maintenance therapy agents. And for instance, during this EBMT 2021 meeting, we had a presentation looking into the different FLAMSA variations and regimens. And because every different centers, different cooperative groups, different countries have tried actually to refine, to optimize the FLAMSA original regimen in order either to increase the safety or even to increase the efficacy, or both, of course. And when we looked into the EBMT Acute Leukemia Working Party registry, looking into the different FLAMSA options, we do have two key messages. I think in the young and fit patient, you would rather try to use a myeloablative strong FLAMSA regimen because patient will not have a high risk of non-relapse mortality, but also you can then strengthen the capacity to achieve disease control and allow time for the immune effect. On the other side, in the elderly, more frail or fragile population with comorbidities, you would rather, based on the registry data, you would rather use reduced intensity, more gentle chemotherapy-based FLAMSA regimens, because then you would like to preserve the safety to have a very low rate of non-relapse mortality, and of course use the transplant as a platform for further immune modulation. So in summary, I believe these FLAMSA regimens are proving to be highly successful and useful in those patients with primary refractory or relapse refractory AML. And I think we should continue to perform research and to continue to have some progress in this field, because many patients are really cured when going through this procedure. And this is, of course, providing a lot of hope while waiting for whatever highly effective drugs or combination without a transplant.